Hello, Jeremiah Cox here, one of the producers of Daily Progress by iiNCHES Foundation, with a special thank you to our friends at KindlyMD for sponsoring this episode. Today, Tim Pickett, founder and CEO of KindlyMD, and Alema Harrington, challenge the existing norm of how healthcare has been done and discuss ways to do things better. We hope you enjoy this episode of Daily Progress by iiNCHES Foundation.
Well, welcome on in, Alema Harrington, broadcaster, podcaster, substance use disorder counselor, advocate in the mental health arena, and the host of our series here on talking about iiNCHES Foundation and the things that are happening with our program. And this is actually our mental health series, and we welcome in Tim Pickett from KindlyMD, CEO, founder, and thought leader in this arena. And we're excited, Tim. We appreciate you taking the time to spend a little time and share some information in this, the world of mental health and wellness, and some breakthroughs that are happening. And full disclosure that KindlyMD is a sponsor or a contributor to iiNCHES Foundation. We appreciate that.
Absolutely.
And so tell us a little bit. This is always interesting to me. KindlyMD, the name, and maybe the origin of that. How did this all come together for you?
Sure. Well, thanks, Alema. I'm really excited to get kind of back into this, this promotion of mental health, and KindlyMD has come a long ways, and I've been a little bit buried in the business side of things for maybe a year and a half. But to answer your question, really, KindlyMD came from, we started out as UtahMarijuana.org, right? Giving people access to medical cannabis and a medical cannabis evaluation, and trying to build some content, clinical, relevant content for people who wanted to use medical cannabis in Utah, and started a company named Utah Therapeutic Health Center, Utah THC. As that grew, when the medical cannabis industry in Utah was really taking off in 2020, 2021, I wanted to grow. We were taking care of the people who needed to use medical cannabis, right? We don't touch the product. We're kind of an adjacent business to the cannabis industry at the time. So that's you quickly, as a clinician, learn that you need to take care of their medications, people's medications. You need to take care of more than just the weed, so to speak. So, and Utah Therapeutic Health Center is kind of that's a Utah name. So what could we do that could potentially branch out in other states and be a little bit more inclusive of things that aren't just cannabis? And I like the name Kindly. Yeah. It does have a little bit of that kind, right? That hint towards the cannabis space, but it's in the background. Yeah. But it also is what we do. We really focus on the patients and just trying to meet people where they're at. And so the name Kindly, and the URL was available, of course, right?
That's always part of it, right?
Yeah. There are some practical things to just, putting something together.
It feels like this shouldn't be a novel idea, but taking care of the patient is almost something that it's like, wow, why would that need to happen? Because it's not happening in the way that our medical or our health and wellness industry works. It feels like it's almost overwhelmed by other entities, and the patient is very secondary, if maybe even, periphery at times. Yeah. And I look at what KindlyMD is doing, and the focus really is on the patient. And I guess, how has that been received? I would imagine that people are like, finally, somebody is asking me, and not the pharmaceutical companies or any other organizations, or at least I get to be a collaborative influence in this process.
Yeah, you've hit the nail on the head. It's really, when you focus on the patient first. So my background is in GI surgery, in emergency medicine, and trauma and critical care, in hospital medicine. And a lot of the patients that we take care of will say that's kind of a top-down approach. We decide what to do for the patient, what's best. We make the decisions. We tell you what to take, how much to take, when to take it. And that's how medicine has been in this country for a long time. And we tell you what's approved and what's not approved, right? The system.
Yeah.
And that pisses people off.
Yeah.
And it's not good for healthcare.
Mm-hmm.
And frankly, it's not good for value-based healthcare either, which I think there's growing research that you've got to engage the patient. So the interesting thing about cannabis is it's not always the right tool in the toolbox for the patient,
Mm-hmm.
but usually when patients want to try it, it triggers this almost like an awakening that patients realize, wait, I can use something that I get to decide when to take it. I get to decide how much. And now I have control. Maybe I should use this concept, this
Mm-hmm.
empowerment for another medication that I'm on, that antidepressant that I'm on, or that Ambien that I'm somewhat addicted to at night. I talked to a patient this morning. Can you just get me off of my Ambien?
Yeah.
Right? Like I'm addicted to it.
Yeah.
I want something different. I'm willing to try something. So if you meet patients where they're at and you listen to them first, and you realize there's a person attached to the illness, or there's a person attached to whatever medication they're on, and you just start there, like it's a no-brainer.
Yeah.
But then you build on the system, and we can talk about that too.
Yeah.
Like what is required to do that in healthcare is not easy,
Mm-hmm.
right? You would think this is just easy. And if it was a cash pay system, I think it would be a lot easier.
Yeah.
But you bring in the insurance and all that structure that the system has, and it becomes it's a tough challenge.
Yeah.
But
It's obviously a hot button right now with the assassination of the CEO of United Healthcare. And so there's, a lot of conversation about what is going on in the insurance industry. And there's a lot of people that are upset. And, it goes without saying that approach to take out somebody that is a part of the system is not the answer. This really is the answer.
Yeah.
Like, we need to have these conversations. Like, what is the solution here, and how do we get the patient back involved so the patient is actually is pleased, maybe even elated about the healthcare that they're getting. And that means that there's more involved than just, this almost like a conveyor belt going on of, and I'm a person in long-term recovery. I was, addicted to opioids for decades, and had multiple back surgeries and dealt with that, and was in, multiple pain clinics. And I know from the patient side of this, once you're in the addiction cycle, how hard it is to get out. One of the things that is intriguing to me is to bring in a BHC, or a behavioral health specialist, that is part of the process, that can identify and acknowledge and understand what is going on, see some of the triggers or the signs that, addiction is starting to play a role here. And we need to address that too, because that's a big part of it.
you have people like me who are trained to, and we're trained some in behavioral health, but we're trained to prescribe. We bring a patient in, we evaluate them, we do the physical exam, we follow our algorithms, we prescribe medications, we order tests, and then that's it. Your 20 minutes is up. We'll come back in 3 weeks. But if you add a behavioral health clinician into that mix at the same point of care, you get a huge benefit. It's not just 2 times, like it's a multiplier effect, because you have now somebody who's only trained in how can I modify the skills that this patient has build a little hope, and then use momentum, use those skills and the hope to build some momentum in their healthcare.
Yeah.
Right? Like, imagine you go back to where your back surgeries are. And if you had somebody who could just come over and say, hey, how you doing with your physical therapy? Why don't you just this week, XYZ, right? And then they check in with you.
Yeah.
You have some accountability to somebody, right? Who's not prescribing, right? And that little piece it makes a lot of difference because you're really pointing people in this direction, right? And if you can just tweak that angle just a little bit, you make a lot of difference in the long term.
Yeah.
And think of the cost savings. Like, I mean, not to rehash like your personal thing, but if you go back and you were to just change 10% at one point, how much the system would have saved too, not just you. So our job at KindlyMD, like as a public company, we try to bring more awareness for the system, like the effects in the system, not just for the patients. It all starts with the patients, but we have we can bring a lot of value to like the healthcare system by reducing costs, getting people back to work sooner, reducing the risk of using more prescription medications. Hopefully we can publish our data, and publish the results that we see, because we get 85% of people off of their opioids, like within 6 months, not off, but like remarkably reduced. Right. That makes a lot of, it just makes a lot of sense. We're just trying to motivate people and give them the skills. Again, it's skills and hope, and then starting to build that momentum. But you got to do it. The other thing that I think is important is there's a couple of things that make it difficult. One, the structure of the healthcare system makes it difficult to bill for this. Like, to make a living doing this is very tricky. And that's probably partly why, I think Select Health tried something like this and then they turned it off. And bigger systems have tried this and they're not, I don't know, maybe they need a lesson from us. All right, come see us and we'll tell you how we do it. It all has to, we really just focus on what's best for the patient. But on the other hand, you also have to speak the same language. The behavioral health person and the provider, the PA, the nurse practitioner, the MD, we all have to be speaking the same language. Like, we have to be heading for the same goal. So that's why integrating behavioral health, the way we do it, we feel like is maybe better, because when you come in, both the behavioral health person and the physical health person, they both know exactly what you want, right? They're both listening to you the same day with the same issue, going over the same medications, and we're making a plan as a team.
I almost feel like the behavioral health clinician, who, as you mentioned, I think this is important to understand for people that are watching, is that you're going to see your physician, but also in that same meeting is going to be a BHC or behavioral health clinician, which, in my opinion, the way I look at it, this is a person that is specifically advocating on my behalf with my mental health and wellness as their priority.
Yes.
And that's something that is unique, that we have not seen in a healthcare situation. And it makes a huge difference, because that person is really looking out for and watching for what is going on with me from a mental health side, which includes me just being in denial or dishonest. I can speak from my experience going to a pain clinic and all I'm looking for is more drugs. But if there's a behavioral health clinician in there, they can recognize the signs of an addiction that is starting to really take off and say, okay, let's take a look at this. And I've got some suggestions that might work for you as, an intervention here, and to reduce the amount of opioids that you're taking. I was taking when I went through this, it was when OxyContin first hit the marketplace and it was exploding. And if there had been somebody that was advocating for me, looking out for the possibility and probability, in my case, of an addiction problem, then it would have at least made that time when I was in full-blown addiction, gotten me into an intervention and into treatment if it was necessary or if it was indicated at that time, a lot sooner.
And they would have been able to tell the prescribing provider, hey, you got to watch out.
Yeah.
Right? These are some signs that this is not going the right direction.
Right.
Right? Because you're either getting better, you're staying the same, or you're getting worse. That's it. And if you're staying the same, but your pills, your consumption of the medication is going up, then something's wrong.
Yeah.
But it takes them both. So, we're trained some, but we're not trained as well as your training in the mental health aspect and the addiction aspect is just better than ours. It's better. Yeah. I mean, maybe it's the type of person that goes into it. I don't know. I don't know what it is, but it really works great. So let me explain how a patient visit, goes with us. So you schedule with KindlyMD. You, normal intake stuff. Yeah. All the normal intake stuff you normally do with your doctor. You come in, you'll see the prescriber, the physician or the PA or the nurse practitioner for 15, 20 minutes, whatever maybe 30 if it's a new patient visit, just like normal. We try to do less mental health discussion in those visits. We try to focus on the physical health and the medications and that type of thing because we can. And then we usually introduce the BHC. You don't have to talk to them. You can. Usually that first initial visit is checking in. What do you want to do? What are your goals and motivations kind of thing? Yeah. We don't focus on, those visits are not therapy. They're not 50-minute, go back in your history, figure out all your childhood trauma. That's a different type of therapy,
we'll be clear, that person is not necessarily a therapist. They might recommend a therapist, but they're a behavioral health clinician.
Yes. So licensed like a therapist, they might be a psychologist or an LCSW, but they're trained. This style of visit is more for something, right? Yeah. We have a goal, we have a motivation. We want to improve health. Yeah. Sometimes I call it always better health, right? We're just looking for always better health. You might be super healthy, no medications, but what are you working on? Yeah. No, something, right? Maybe you listen to Peter Attia and you want to try something that's like longevity. That's fine. Talk to the mental health expert, right? How to do that. And maybe you're really working on chronic pain or you're working on the ambient thing I talked about before. And so we're just going to work on that. Yeah. And then you may come back more frequently just to see the BHC, right? We can do that. We can do telemedicine. Yeah. Sometimes that's good because with our opioid patients, for example, they have to see us every month, right? Yeah. But we would like to check in with our patients from the mental health side. Maybe it's just a phone call once a week. Yeah. It's just a check-in, right? Hold yourself accountable. Are you feeling early? That type of thing. How's your function? How's your physical function? We do that a lot with our injured patients. You're just checking in.
Yeah. And I think that this is an interesting topic here because you mentioned that you might be feeling early, going through your medication too fast. And maybe the physician is like, okay, well, let me either up your dose or whatever the case may be. But the behavioral health clinician can look at that and say, okay, but so why is that happening? One of the buzzwords that we hear is harm reduction. I look at this interaction a lot of times, especially as a person that's dealt with chronic pain in my life. And thankfully, my pain is under control. But there's a lot of fear that goes along with it. And the reality is we make horrible decisions when we're acting out of fear. And what I love about this behavioral health clinician component is there's an opportunity to identify and then address fear and to give that person, the patient, give them some sense of calm. Like, okay, I don't have to be worried about this. Like I have people that are advocating for me that care about me.
Yeah. And you don't have to be afraid of, so what I hear you saying is you don't have to be afraid that you're using your medication a little bit faster because you have that advocate. Yeah. You're like, well, they're going to believe me. They're also going to know whether I'm telling the truth. Yeah. right? And they're going to hold me accountable for that. But that's all towards the thing that we all want to do, which is get a little bit better and a little bit better and take things like just stepwise. So we often in pain treatment, you talk about people who there's patients who need more and more and more, and they're filling early or using more of their medications.
There's a tolerance component to that.
Sure. Sometimes there's physical things and sometimes there's mental health things, but oftentimes patients will run from provider to provider. They'll get fired. They'll fill early and they miss their out of their contract, their pain contract, and then they get fired from the clinic. So they have to go, and then they get a reputation.
Yeah.
So we have collected a lot of patients that are like this. Yeah. And we've had staff meetings where people say, well, if they fill early, we need to fire them. My comment has always been, they need to come see us more.
Yeah. My experience, if that does not get treated, and this is my personal experience, and I see this in my own work with addicts currently, is that if that's not addressed and you just fire the client, they will end up on the street on heroin.
Yeah.
I ended up at Pioneer Park buying heroin. And so there's got to be a better solution to that, where the fear is, okay, I'm just going to lie to my physician and tell them that, something happened, I lost my prescription, whatever, in order to refill early. Yeah. But if I have an advocate there that understands, okay, I'm recognizing the drug-seeking behavior here.
Yeah, right.
And let's treat that instead of let's fire that guy.
Exactly. Like that means you probably need to be seeing me twice a week.
Yeah.
Right? Instead of once a week or once a month, you need to be checking in more. I just feel like those patients need more care.
Yeah.
Now, granted, you're not going to win every battle, right?
Sure.
And depending on where people are in their what I would call like a recovery arc, right? You're not always going to get somebody who's really ready to take that step.
Yeah.
But you're going to be there with the resources. You're going to try to be in network, right? With their insurance provider, so that you have all the tools and all the resources, so that when they're ready, you're there.
Yeah.
Right. And it doesn't matter if it's an addiction, if it's cholesterol, if it's diabetes, if it's weight loss, if it's, I want to try cannabis, or I have cancer and I'm going through this big ordeal with pain and nausea, then you just try to break it down. Let's one thing at a time. You're there for the patient, integrate the whole person. And that's back to what we were talking about at the beginning. That's how healthcare should have been.
And I love that this is not, at this point with KindlyMD and the work that you guys have done over the years, is no longer theoretical, right? This is actually happening. We're seeing positive results where people are reducing, sometimes dramatically, or even getting off medications. Like maybe you can speak to what you have been able to see as far as success is concerned with this type of program.
Oh, sure. I'll take something simple.
Yeah.
So you take antidepressants, for example, and I'm a fan of antidepressants when they're needed, because if the more depressed you are, the more likely an antidepressant will work for you. The less like actual depression symptoms you have, the less likely that it actually is working, and compared, in the studies. But those drugs were designed for a 6-month course. They were not designed for forever use, even though that's what we tend to use them for. And we have patients that will come in and didn't know that. They didn't even know, nobody ever told them, well, actually, this is a 6-month course. And then we kind of reevaluate. Yeah. We've had just countless people learn that that's the case, use something different. Sometimes it's a little cannabis. Sometimes it's a little bit of mental health therapy or the BHC model, and they reduce their use or get off of one antidepressant. You would think, oh, that's pretty simple. But there's a lot of people in that camp and there's a growing number of people who want to get less. They want to use less prescription medication, right? Less synthetics, Ambien. This is like bread and butter for us. Like, you want to reduce your use of Ambien? No problem. Yeah. Right? Like, there are ways we can test. while you're falling asleep. Again, the sometimes it's anxiety that keeps people up. Their brain is just spinning around. But this model really works well. The opioids, again,
a medication that is for acute,
yes,
severe,
not designed
or
for a long
pain,
time, right?
Right, and not right, exactly.
Yeah, I mean, we would take people in surgery, we cut them open, and that is why opioids exist.
Yeah.
Right? We'd put them on, a ton of them. You'd say sometimes you'd be like, hey, we're going to have to deal with this physical dependency because you have had an amazingly big operation and all this trauma, and then we're going to have to deal with this.
Yeah.
Statistically, 1 in 10 of those patients will have a problem, right? So 9 out of 10 don't have problems, and we just send them on their way. So
and they're able
Kindly
to use it as prescribed and then beyond.
Yeah.
Yeah.
So at Kindly, we'll take a post-op patient who's concerned about the use of their opioids post-op. So we'll see them maybe pre-operatively, and we'll talk about their post-op pain, like what's the plan, and then we'll help them. We feel like we do a good job at reducing the risk of opioid dependence or the physical dependence in cases like that. So we kind of fit. We put patients into kind of, if you were to simplify this, we put patients into kind of quadrants. Physical function, you have good function and poor function, and you have coping. You have good coping and you have poor coping. Yeah. So we fit best in the poor function, poor coping quadrant. Yeah. And then we filter into those other quadrants kind of as needed, right? Sometimes you would say these people don't really fit in the healthcare system in general. When I worked shifts in the ER, you can tell you're what we call in medicine your spidey sense or your lizard brain. You have a patient come in and you're just thinking, you know what, you're not going to do very well, right? And instead of referring you over here, I'm going to refer you to you need a referral source to Kindly. So, for example, we work with the Veterans Court, the problem-solving courts in Utah, and the veterans have, not an official VA policy, but a local judicial policy says that if a vet comes in, they get in trouble with the law, they're using opioids, they're using cannabis, or one of the two, and they need a system like this, then they'll specifically send them to us, because we have this integrated service line. Yeah. And we tend to get better results than somebody who doesn't. It doesn't mean we're for everybody, although we would accept everyone. But you get the point, right? Kind of where we fit.
Is in those two categories that you mentioned, which the coping skills
the coping and the function
health is not great. That person typically will not get treated, or will get treated with a prescription and that's it.
Yep. Those patients cost the system more money. Their health outcomes are much, much worse over time. They miss more days at work. And so that's what's best for our system, like our KindlyMD model, the integrated behavioral model. And I think everybody should do the integrated healthcare model. I think it should become, and I do believe that it will become the standard of care one day when we figure it out. When the system figures out that this is how people want to be treated, I think this will happen. But we're still, I would say in medicine in general, it's early adopter stage. We're a good referral source. We're good if people can find us. We're still small, so.
Well, we're hoping that this will continue to grow and that the word does get out. I think one of the roadblocks is when you're talking about medical cannabis, there is a stigma to that
still,
and there's been a lot that has been done over the years to try to to try to deal with that. And I can speak from as an advocate in addiction recovery. There's been such a stigma for addiction, and even though the medical profession has identified it since the 1950s as, a mental health disorder. It still is looked at as like, well, that's just a choice, and they're paying the price for the bad choices they made. And we have so much more information now. And I think that similarly with cannabis is we're getting to a point where people are understanding that it's not for everybody, but this is something that is available and will work for a good portion of the population. But there's still that stigma. How do we overcome that?
That's a great question. My vision is to have everybody in America, we all have Tylenol in our cupboard for a fever. We all have ibuprofen for a headache. And we all probably should have a tincture of THC for, when we can't sleep, or when we're having a procedure, or when our back bothers us, or something like that, right? I mean, it should just be that simplified, that straightforward. It should just be medicine. I think destigmatizing cannabis it's getting a lot better. I think there are two kind of parallel paths that are happening right now, in my mind, with cannabis. You have the recreational or the adult use like industry, and for better or worse, they are driven. That's a business. It's driven by profits, and it is a highly regulated and very, very expensive. So I don't blame them for trying to go after the high dollar buyer, right? The 21 to 35-year-old who uses, an ounce a month. I guess I don't blame them for that, but I think that runs counter a little bit to the destigmatizing medical cannabis and then making it legitimate. So there are so many more people with osteoarthritis, with arthritis, than it's just a growing number of people as the patients age, as the population ages in the US. Those patients are going to be put on ibuprofen, Tylenol, Celebrex, sometimes opioids, right? In pain circles, they talk about their little old ladies or the old guys who just use a couple of hydrocodone. Like, why? Why is that the standard when a tincture of THC is not included in the algorithm? So we have a project that collects a lot of data around cannabis use and opioid use and other medication use and physical function. And we're trying to develop an algorithm, because I think if we can create an algorithm for medical cannabis that when you go to the hospital or when you go to a provider, they just have an algorithm, and cannabis is just part of that algorithm. It's very simplified. And yes, it's different than the adult use industry, right? It's not craft beer. It's boring, right? Tylenol is boring. We don't want it to be fancy. We just want it to be boring. And that part of cannabis should be boring, right? It should just be, take this, start with this. So we try to make it a little bit more boring in medicine, so that it is more legitimate. I also think that, we're in Utah and there's lots of politics around this, but somebody with a white coat and a stethoscope is probably going to get a lot more credibility than when you go to the dispensary and you're getting your advice from the person behind the counter. They may know a lot more than the person with the white coat and the stethoscope, which is why we have to empower those people. We have to empower the providers with the education. And again, the algorithm has to be pretty simple, so that they'll feel comfortable using it more. I don't know if that completely answered your question, but that's kind of my vision of how cannabis fits in the system. I think it will happen, but I think if we were to go adult use, I think you skip over that legitimacy. And I still have a lot of patients who come in and they don't want to go to the dispensary. They don't want it. They feel like they're still going behind the beaded curtain, right? To get their drugs. And wouldn't it be nice if I could just go to my local pharmacy and I could just get that thing that they had? And again, just a couple of boring choices. I just like that model better, because I find that specifically my patients that are 45 to 85, they, they just want to learn how to use it. They want it to be useful.
Yeah.
Right. And then they learn, and I've got some patients who are actually quite old. They learn to use it.
Yeah.
And then they start using it for other things, right? For the anxiety that they have. They'll just use a couple of drops or a quarter of a gummy, right? When they go to the family party and they want to deal with their family and they just find that they're a nicer
so much
person.
anxiety that's surrounding that experience. Yeah.
Yeah. But if you don't know how to use it, I mean, my encouragement to people is try using it early, because when you get cancer or you have that surgery and then you say, oh, I want to try cannabis. Yeah. It takes a good month or two to learn how to use it. Yeah. Right. In a way that you understand the dosing.
Yeah, an effective and responsible way. Right.
Yeah. And I think, so if it takes you that long, then it's a little bit better if you could use it a little bit earlier, right? Like learn how to use it a little bit earlier. Yeah. We have a lot of patients that come in, they're on hospice and they're kind of towards the end of life or something. And I just wish that there was that's why I wish there was a little less stigma too. It's because I wish they would have learned to use it a little earlier, because it's a lot more effective. Yeah. Right.
If your physician had looked at it, let's say for, insomnia or whatever the case may be, there's plenty of indications for THC. And if that had been, programmed earlier on, then when you do have end of life hospice or even, a pretty traumatic surgery, then
you would have known how to use it.
This is a resource for me that is certainly much better for me than to be going out and leaving the hospital with 100, oxycodone, 10 milligrams.
Right. It should have been normalized, right? If we normalize it earlier, then it will be a much more useful product because it's relatively safe, right? For almost any age group.
Safer, certainly
than the opioids.
The alternatives that are being prescribed fairly heavily.
Yeah.
I think one of the questions ends up being, okay, so now I've got a tincture of THC and, are my kids going to come after it? And I know that KindlyMD, that is not prescribed for somebody that is under 18, if I'm not mistaken.
So in Utah, you've got to be 21 unless you get a compassionate use board approval. So you can get a compassionate use board approval for pretty much any condition. It's quite a process. Yeah. And you have to have your normal primary care or your normal specialist do the work to get you approved in that case. Yeah. But it is possible. But yes, mostly 21 and over, and you can get access to medical cannabis. And when it comes to your kids or things like that, you don't leave your opioids out on the counter. So don't leave your weed out on the counter. Yeah. Right? There should be common sense. When your kids ask what this is, you should look at them. You should say that shit is medicine. Yeah. You don't touch that. Right? Just treat it but that again, normalizing it, putting it in its place, creating a place for it in the medicine cabinet, and then it's okay, right? Yeah. It's the liquor cabinet. It's the same concept. Yeah. We do this with a lot of other things, but we get so scared about it with cannabis. And I don't know, it's not that scary.
Yeah. There's been decades of propaganda from, reefer madness, which I'm old enough to.
Oh, you should see that. I've got a Deseret News article of a link letter. It's marijuana is terrible. I have it framed in my office. Yeah. Because and I have things from high school. My kids are going to have birth defects and all kinds of stuff. Yeah. I'm glad it's not like that anymore.
Well, as the industry continues to develop, where do you see KindlyMD? My perspective, my observation is that there's a lot of groundbreaking that is taking place with Kindly to be able to do this. And how has that process been for you? It's got to be to some degree a labor of love that you would have probably bowed out a long time ago if it was not.
Yeah, so I've got a sister that's has colon cancer and really never had an algorithm, right, for medical cannabis. I got into it for that. A really good friend of mine who's an alcoholic who used some cannabis and has been able to stay sober and use that as a tool, one of the tools in the toolbox. He's a big AA guy. So there's this personal side. I love learning. And I like doing things that are people just in medicine. There's always these things that people do that have always been the way things are done. And I've always questioned that. Like, well, show me the rule that says you can't be in network and use medical cannabis in the treatment program to get somebody off of opioids. And nobody could show me the rule. So we decided, well, we'll just go get in-network status. And a couple of years later and a lot of gray. And so we don't know of another company really in the country that has in-network status with large healthcare providers, right? Large contracts, Cigna, United, Blue Cross, Select Health, who is using medical cannabis as one of the tools in the toolbox. Integrating behavioral health care. I think that helped in our case, right? Having both providers there, because and really trying to legitimize it from the inside. There's been a lot of companies that have tried it from the outside, doing a cash pay model and trying to change things from the outside. I don't feel like that's going to work. Having worked in the big hospital systems, like those folks are not giving credibility to anything that's outside like that. You got to be in network to make the thing change. So our driving force is really person by person, just doing what's right for the patient. We know this is the right thing to do. It makes sense to us. We've hired a great team of people who are good at this, right? Who are believers in this type of patient care. And so I think for the future of us, it's getting the word out so that this type of service line, I wouldn't mind a few more competitors. That would be more people getting taken care of. And, I've had a lot of people cut hair in my life, as like my uncle and my mother and my sisters-in-law. And they always tell me the same thing. They're always like, well, no, I can't cut everybody's hair. Right. So I can't take care of every patient. There needs to be more facilities that are doing this. And on our side, we're going to grow. We're going to buy clinics that are pain clinics, interventional pain clinics and primary care clinics. And we're going to overlay the system into those clinics so we can expand our footprint, so we can get access to more patients. We're going to expand our contracts with the VA and other big healthcare systems so that we can see more patients. We're going to do more telemedicine, behavioral health specifically. I think there's a really big need for the behavioral health industry to see more patients. And I think with opioid prescribing and with physical medicine, we have to do a lot in person. We're never going to be the Four Hims, right? Model when it comes to prescription medicine. For
the medications that we're talking about. Sure.
Yeah. And so we're going to have footprint in other places. But we can overlay the mental health part, the BHC part, into existing clinics in other states, right? We can teach those providers how to do this. And we can overlay our mental health support and our education to that. So I think we can help a lot of people if we're just focused on the mission of just doing what's right for the patient every time they come in, making sure they get taken care of, and then trying to get more and more people to know about this, to understand how to do it. And that's really our plan, right? With being a public entity, and trading on the NASDAQ, that there's a lot of opportunity there and a lot more exposure, which we really, we want to do that. It also gives us access to buy more clinics and go faster. because I don't think this can wait.
Yeah.
I think that the need is pretty. COVID showed us that the mental health is like, it's a burning fire. The house is on fire.
Yeah. You mentioned that it's a public company. Maybe if you can share with our viewers, like, okay, if I'm looking for an investment opportunity,
oh, sure.
How do I do that?
Absolutely. So our ticker symbol is KDLY. We're traded on the NASDAQ. We don't know of another NASDAQ company that does what we do. Kind of cannabis adjacent, mental health, and in network with big providers. I think there's it's fun. It's wild. Yeah. But KDLY, KindlyMD.
Yeah. I think this is important too, because one of the parts that is to a degree a result of, the companies that have just come out and like, this is where you get your medical card so you can get weed. It's like there's a whole business that is that you were talking about. And this is not that. This is integrated holistic health care. And so certainly THC or medical marijuana is one of the tools in the toolbox, but it's so much more than that. It's really the integrated holistic care approach.
Correct.
Yeah.
We take care of a lot of patients in the medical cannabis program in Utah. I think more than any other of the companies out there. That's how we got our start.
Yeah.
It's how a lot of people find us. A lot of people we get a lot of referrals. We tend to get a lot of referrals, from the Huntsman and from other surgical centers that they're running into patients that want to use medical cannabis as part of their treatment protocols. And we're in network in their system. And so we can manage that sort of thing. We don't manage medical cannabis on its own under insurance.
Yeah.
Let me be clear. That's not allowed still. One day, maybe it will be when it gets rescheduled. But we just are part of the system that way. So if somebody wants to use medical cannabis and wants to come to us, we do that as well.
Yeah.
But we definitely do it in a more, I would say, of clinical way.
Yeah.
Right?
I would say a more
Pretty
responsible way.
Yeah. Thank you.
Yeah. I think that's the approach.
Yep.
And to offer, again, integrated holistic means that there's lots of options. It's not just, I think that the medical community, my experience has been that there are some influences that direct how that treatment goes.
Right.
And if we could be open-minded to, there's actually a lot of different options available out there. And with the advertising that takes place on television, and who knows, maybe that changes at some point. I believe we're one of the few countries that even allows that for the impact that it has on a patient's decision. Almost feels criminal, might be too strong of a term, but there are
a lot of people who would agree with you.
Yeah. And so to be able to have, for lack of a better term, a grassroots or an understanding that there are other options out there but people just have not been exposed to it, or their exposure has been, stigmatized. Yeah. I think that's where KindlyMD, comes in. And again, it's not just the medical marijuana. It's really changing the way the system operates altogether.
Yeah. Yeah. I think that's a very good way to put it.
Yeah. I'd love to have you come back and we can talk about some other topics, because there's so many things that I'd love to have just a mental health awareness conversation about, and including, whether or not we get rid of daylight savings, which is, something that's kind of,
I can't wait. Right? I can't wait. I want daylight. I'm on the daylight savings all the time guy, but yes, can we come back? I'll come back anytime. Yeah. Don't be afraid. And I've got a few opinions. Yeah. And I love like I said in the beginning, I love to learn. Yeah. And so I'm constantly like reading the research. What's good, what's good and bad. We get so many questions in clinic, And, we have a provider chat, and we're always chatting about like, what are the questions people have using metformin for a longevity drug?
Mm-hmm.
The GLPs, the weight loss drugs.
Yeah.
We do a ton of weight loss now in clinic, and we're doing a ton for chronic pain because, if you can lose 20 pounds, your back feels a hell of a lot better.
I'll tell you, it's made a huge difference in my dealing with my own personal pain. I lost 30 pounds in the last couple of years, and it had a huge impact.
Yeah.
I was able to do that without being on one of the medications out there. But even then, if you bring in a behavioral health clinician that's not just looking at, okay, what are the prescriptions we can provide? Like, what are some behavioral changes that you can make that would impact your overall health and wellness and reduce your weight? That's a big deal.
Oh yeah. Yeah. I would be more than happy to talk about any of that sort of stuff.
Well, you mentioned, and I think that this is also an important part of what KindlyMD does, that you are, if I'm not mistaken, in network.
Yeah.
And so how do people, let's say, I have a particular healthcare insurance, how do I find out if KindlyMD is part of my program?
Best thing to do, if you have a health condition, you're looking for a new primary care, you are a pain patient, you've been on opioids, you want access to medical cannabis, or you just want to know more about that sort of stuff, go to kindlymd.com and call us.
Yeah.
Just call one of the MAs, one of the staff. They're good at figuring that out. Whether you're in network or not, they can do a check right on the phone. Usually it takes about 5 minutes to run a check on your insurance, see what your copay is, what your co-insurance is, what it would look like to come see us. And we're opening up an office in Ogden on the Ogden Regional Campus there next month. We have our location in Murray. We also have some satellite locations in Bountiful and Provo that you can come see us at. So kindlymd.com, and just give us a call. We can answer your questions.
Tim, thank you. Thanks for the time.
Thanks,
Appreciate
Alema.
you.
All right, stay safe out there.
Okay.
We hope you enjoyed this episode of Daily Progress by iiNCHES Foundation, sponsored today by KindlyMD. Join KindlyMD in their mission to revolutionize healthcare. Visit kindlymd.com and click on the Investor tab in the top right-hand corner of the website. You can also visit nasdaq.com and search stock symbol KDLY. You'll find a lot of news and other information there. Thank you for watching and listening. We invite you to subscribe and share your thoughts. If you have a topic you'd like us to tackle or someone you'd like us to interview, please send us an email to progress@inches.org. That's inches spelled with 2 I's. Let's keep finding ways to get better, even if it's only by inches daily. And remember, inches become miles after a while. See you soon.